There is a component for first year students called as early clinical exposure. So you have got 2 more days, today and tomorrow. 27th will be your test on these 2 cases, and 28th will be MCQ item analysis discussion. Next slide. A 66-year-old male complaining of chest pain is brought to the emergency room by ambulance. The pain began 6 hours ago and has become more severe over the past hour, prompting him to call emergency services. He describes the pain as retrosternal, pressure-like and non-radiating. He endorses some mild dyspnea and nausea accompanying the pain. He has also noted intermittent palpitations since last evening. Next. He has a past medical history of hypertension, not currently under treatment, and tobacco use of 1 pack per day of cigarettes for the past 47 years. Vital signs on arrival to the emergency room showed a blood pressure of 160 by 100 millimeters mercury, a heart rate of 92 beats per minute, and a respiratory rate of 18 per minute. His physical examination is unremarkable. He reports no allergies and no medication use. So you suspect that he could be having myocardial infarction because he has chest pain or discomfort which is more than 30 minutes. For diagnosis, you require chest pain continuously for more than 20 minutes. So here he had more than 30 minutes and are not relieved by rest or nitroglycerin under the tongue. Because you should differentiate ischemia, which is also chest pain, because of cardiac origin, and infarction, which is also chest pain of cardiac origin. Here it is continuous for more than 20 minutes, and myocardial ischemia will be relieved on rest. The pain occurs during exercise, and here it is not relieved by rest. Ischemia will also be relieved by nitroglycerin under the tongue. Why do you put nitroglycerin under the tongue? Nitroglycerin is a coronary vasodilator. It can also cause other vessels vasodilator. If you swallow nitroglycerin, you cannot control the dosage. That may cause severe vasodilatation and hypovolemic shock. Another thing is nitroglycerin, if it is swallowed, it will go to the stomach, divided and absorbed, go to the liver, where much of it will be destroyed. First pass effect. So you put it under the tongue. The moment you feel relief of pain, you spit the nitroglycerin out so that you don't overdose yourself. And from the tongue, it bypasses the liver and causes direct vasodilatation. But infarction, the pain will not be relieved with nitroglycerin. He is a smoker, which is high risk. He has hypertension, which is high risk. Now there are other high risk conditions which you can control. Hyperlipidemia you can control. Diabetes you can reduce and control. Sedentary lifestyle you can change. Reduce intakes of fruits and vegetables, you can increase them. Psychosocial stress, abdominal obesity, these all are things which can be improved. And there are other risk factors in him is that which cannot be changed. He is a male gender which is higher risk than female gender. He has got a family history and age. These are things that you cannot change. The terms heart attack, cardiac arrest, heart failure. Myocardial infarction is also known as heart attack. Occurs when the blood flow decreases or stops to a part of the heart, causing damage to heart muscle. Most myocardial infarction occur due to coronary artery disease. In cardiac arrest, the heart stops beating. This can be because of myocardial infarction, and it needs to be restarted, so you use a defibrillator. Heart failure occurs when the heart muscle fails to pump as much blood as the body needs. That means, heart is weakening and weakening, eventually it will stop. So the cardiac arrest, heart stopping, can occur because of myocardial infarction, or it can occur due to heart failure. In heart failure, there will be back pressure to the atrium, which will cause back pressure too, depending on whether it is left heart failure or right heart failure. If it is a right heart failure, it will back pressure to right atrium and then peripheral edema. And if it is left-sided failure, back pressure to left atrium, which will cause pulmonary edema. So edema is a sign of heart failure, because the management of the two is completely different. In heart failure, you have to give digitalis, which improves the pumping power of the heart, which is not there in myocardial infarction at all. So just that the heart has stopped beating, you cannot treat it anyway. First it has to restart beating. Then you have to find out whether it is MI or heart failure, because based on that the treatment differs. What is this coronary artery disease? As this diagram shows, the top one is the free flowing of blood. A thrombus which is formed in the wall causes the blood flow to reduce to a slighter extent. And here the thrombus goes on increasing the plaque, lipid plaque, which further reduces blood flow. This progression is called as coronary artery disease. Next slide. Acute coronary syndrome can manifest as unstable angina, which is not due to a block in the coronary, it is a coronary spasm, which typically occurs in cold environment, or if you are taking cocaine or other emotional stress, that causes acute coronary spasm, which will cause pain. But it usually does not end up with myocardial infarction. Myocardial infarction with ST segment elevation on ECG is called as ST elevation myocardial infarction, STEMI, due to a transmural infarct that is occurring through and through the wall of the heart. Myocardial infarction without ST segment elevation on ECG is called as non-STEMI, due to subendocardial infarct. So now, the point to be remembered is that either you can get wall-to-wall in endocardium to pericardium infarct, or you can get just a subendocardial infarct. You don't get a subpericardial infarct alone. Let's see why that happens. This is the, the platelet plug which has blocked that small gap which causes myocardial infarction. When you say myocardial infarction, the definition is not ischemia, the definition is not ECG changes, the definition is not change of motion of heart wall, it is not demonstration of thrombus or an angiogram. The definition of myocardial infarction is elevated cardiac biomarkers with a rising trend. Elevated cardiac biomarkers with a rising trend, and one of 1, 2, 3, 4. So the primary thing is there has to be elevated cardiac biomarkers to call it as myocardial infarct. And either symptoms of ischemia or ECG changes or motion of heart wall as detected by echocardiogram or demonstration of thrombus or an coronary angiogram. Now, sudden cardiac arrest, which is caused by HT is what?
Hypertension.
Hypertension. So, sudden cardiac arrest caused by hypertension are because of 12 factors. 6 starting with H: hypovolemia, hypoxia, hydrogen acidosis, hyper or hypokalemia, hypothermia, hypoglycemia or hyperglycemia. Any of these can be the cause of sudden cardiac arrest because of hypertension. Tablets or toxins such as drug overdose, tamponade, tension pneumothorax, thrombosis, thromboembolism, and traumatic cardiac arrest. So these are the reasons why hypertension can cause cardiac arrest. What is this golden hour? A STEM ST elevation myocardial infarction, which causes excessive ischemia, results in which will cause ventricular tachycardia. Ventricular tachycardia eventually results in ventricular fibrillation because tachycardia is increased rate of ventricle. Remember, nourishment of the myocardium occurs when the ventricle relaxes. The ventricle is not relaxing, quickly contracting again. So that will result in ventricular fibrillation, which will eventually result in asystole or death. This whole process from STEMI to death can occur within 1 hour. That's why treatment has to be done within that golden hour. Now, what are those cardiac biomarkers which we discussed? The most specific and the most sensitive biomarker is troponin. You can see that bold red line which has gone up and come down. And look at the left side, multiples of the upper limit of normal. So troponin rises to 50 times above the normal level, and the peak occurs in 24 hours. It quickly rises. Creatine kinase, CPK-MB, creatine phosphokinase, CPK-MB, is seen in that green dotted line. Now, what is this CPK-MB? Creatine phosphokinase level can rise in skeletal muscle damage, it can rise in cardiac muscle damage, it can rise in brain damage. The CPK which is occurring in brain damage is called as CPK-BB. That which occurs in skeletal muscle damage is called as CPK-MM. And for the creatine kinase, which is a cardiac defect, is partly resembling the muscle damage, is partly resembling the brain damage, so it's called MB. Now MB incidentally is acronymized as myocardial band. CPK of myocardial band. Actually it stood for part muscle, part brain resemblance, MB. The peak is 12 hours. Aspartate transaminase SGOT also rises, and myoglobin, if you notice, the first one which you see even before the red one is myoglobin is the peak seen within 2 hours. So the earliest rise will be seen in myoglobin, but specific myoglobin can be skeletal muscle damage also, whereas troponin is classical for heart only. Next, what are the ECG changes that occurs? Remember, the P wave starts from SA node and goes towards AV node, that is downwards towards the left. Now, lead 2, chest lead 2 is in that direction in which the atrial contraction occurs. So, when the impulses are flowing from SA node to AV node to in the direction of the lead 2, the lead 2 will show an elevation. So, the impulses are flowing towards the lead, it is will show a positive deflection. If the impulses are flowing away from the lead, it will show a negative deflection. So then This is the classical of chest limb lead 2. In limb lead 2, the septal contraction is seen going away from limb lead 2. That's why it shows the Q complex. And then apex contraction is exactly in the direction of the limb lead. So it shows the acute rise, that's called R. So by definition, the first downward impulse before the first positive impulse is called Q. If there is the first upward rise, it's called R. Second upward rise is called R dash. After R, whatever the depression is called S. And if there are double depression after R, it's called S and S dash. Q is restricted to before the first upward deflection. And then there is an ST segment. The heart ventricle contracts during QRS. Atria relaxes during QRS. Now if you look at the atrial contraction, P wave, it's so small. So its relaxation will be even smaller. So you will get submerged in the QRS complex. You will not see the atrial relaxation. The ventricle relaxes in the T wave. So ST segment or rather QRS and T, QT interval is where the ventricle is in contraction. And notice, major part of ventricle is in QRS complex is R wave. That means primarily the impulses are going from endocardium to epicardium. That's why it shows a positive deflection. Now, if the relaxation occurs from endocardium to epicardium, then T would have been inverted. Because if contraction is from QRS complex to QRS, shows the elevation from endocardium to epicardium, relaxation from endo to epi should have shown an inverted T. But it's showing an erect T, which means the relaxation of the heart starts from epicardium and goes to endocardium. Why does that occur? Physiologists had discussed this topic with me. They said it has been stated in our books that the epicardium has got more calcium channels. So it quickly relaxes. And the endocardium has got fewer calcium channels. So relaxation takes a longer time. So the relaxation wave starts from epicardium to endocardium. They asked him, why are the calcium channels more at the epicardium and less in the endocardium? Because the epicardium should relax first, then the endocardium. Now this is called as circumlocutory thinking. The reason is endocardium and the inner part of the muscle has got papillary muscle complex and chordated in starting from papillary muscles, which closes the AV valve. If the endocardium relaxes first, papillary muscles will relax first, the AV valve will open and there will be backflow of blood. So it ensures that the first to contract papillary muscle, last to relax is papillary muscle. So the calcium channels are created more in the epicardium, so that they relax first and papillary muscles relax last. So there is no backflow of blood into the atrium. That's why T wave is erect. Next. In ECG, before the ECG waves are seen, you see something like this. The left hand side rise up and down. 1 millivolt is 10 millimeters high up. That means each small box is 0.1 millivolt. So 10 millimeters up is 1 millivolt. And time-wise, one big square is 200 milliseconds. One small square is 40 milliseconds. One big square is 200 milliseconds. 200 milliseconds. 5 big squares make up 1 second. 5 big square makes up 1 second. and one small square is 40 milliseconds. Now, limb leads are seeing the heart in coronal plane. Seeing the heart in coronal plane. So, heart is cut into, like a face of a clock in a coronal plane. And here you see the limb lead 1 is 0 degree as x-axis. Limb lead 2 is 60 degree as 5 o'clock position. 3 o'clock, 5 o'clock, and limb lead 3, 120 degrees from 0 is 7 o'clock. So limb lead 1, 2, 3 are 3 o'clock, 5 o'clock, 7 o'clock. AVL, AVR, AVF is 2 o'clock, 6 o'clock, and 10 o'clock. 2 o'clock, 6 o'clock, 10 o'clock. You wanted it to be equally distant. It says 30 plus 30, 60, and here it is 60 plus 60 plus 60, 180. Now AVR would also have been taken at 4 o'clock, directly opposite it. So, but the 4 o'clock and 5 o'clock will resemble each other very closely. So, just to make sure, because 5 o'clock is the main direction in the heartbeats. So, 4 o'clock and 5 o'clock would be very minimally different. So, to make it distinctly separate, it is kept at 10 o'clock, also called as the northwest position. No impulses usually go in that direction. So, QRS, the entire complex in AVR is inverted. Next slide. But for us it might be difficult. For a computer it's not difficult. So computer interprets nowadays ECG pretty easily, so it can clearly differentiate what is 4 o'clock and what is 5 o'clock. So sometimes the minus AVR is plotted and then the computer is able to read it pretty easily. In a chest lead, you have to understand the cross-section of the heart. It's quite very obvious that the thin-walled right ventricle becomes crescentic shape and that of the left ventricle is 3 times thicker than the right. Yeah?
This is seen from below?
This is in horizontal plane.
It's a horizontal plane but seen from below or above. Like we are looking at the cross-section.
You are looking at the patient's chest from above. Patient's left is on your right. Na?
Yes, sir.
You imagine the patient's chest is cut.
Those are the papillary muscles.
Yeah.
Those are the papillary.
That is the left side. This is the right side.
Yes. Patient's left is on your right. Patient's right is on your left.
So that means, sir, we are looking it from below. We are looking like patient is lying down like this.
No. Imagine patient standing. Because you have to describe a chest lead, which is in horizontal plane.
So now if you are looking from above, this is the right ventricle and that is the left.
Yes. You can easily make out that the thin wall is the right ventricle. Now let us assume the thickness of right ventricle is x. The thickness of left ventricle is 3x. What would be the thickness of the septum? Average of the two? Sum of the two? Or will it be 3x itself? This diagram shows that the septum is equally thick as compared to the rest of the ventricle, and definitely much more. See, if x and 3x, the average would be 2x. So do you think that septum is only 2 times thicker than the right ventricle? It's not, it's almost 3 times thicker. Remember, Newton had 2 cats, a bigger cat and a smaller cat. The cats wanted to come in and out of his room, but he didn't want strangers and friends and other people disturbing him in his studies. So he asked his carpenter to make 2 holes, a bigger hole for the bigger cat and a smaller hole for the smaller cat. The carpenter asked, why do you want 2 holes? I'm paying you, you make 2 holes. Then he realized that the smaller cat is always following the mother cat through the bigger hole. In other words, when left ventricle is thicker, because it has to pump to the entire systemic circulation. The septum, if it is thinner than the rest of the wall, it will get ballooned out. No use. Double the thickness doesn't matter. For right ventricle, it doesn't require anything extra. So 3x is enough for the septum as well. Right ventricle, a little extra strength doesn't really make a difference. The power of the right ventricle is based on the remaining part of the wall. A chain is as strong as its weakest link. If the septum was weak, the power of contraction would also have been weak. Now, let us look at these chest leads. They are placed V1, V2 is the V1, V2 changes will be seen if there is a problem in which wall? It will be seen if there are changes in the septum. Look at the 3 times thicker septum. Right ventricular wall will not show any changes. Right ventricular wall also doesn't undergo ischemia because its requirement is much lesser. So V1, V2 changes are because of chest leads. V3, V4 changes are because of anterior wall. V5, V6 changes are because of free left wall. Some people keep even a V7, V8 behind. That is trying to view from the back side. But standard 6 leads, V1 to V6, septum, anterior wall, free left wall. Next slide. When you are seeing in ECG, you have to measure the heart rate. Normal heart rate is 60 to 100. Nowadays they say it is 50 to 90. But 60 to 100 is good enough. The rate is described as 300 divided by number of big box between R and R. If you want to be, so number of big box must be between 3 and 5, between 2 R waves, because 300 upon 3 is 100, 300 upon 5 is 60. So the number of big boxes between 2 R, consecutive R, should be between 3 to 5. If you want to be very accurate, what the computer does is 1500 divided by number of small boxes between R and R. Rhythm. The normal sinus rhythm is produces the prototypical pattern of P wave, QRS complex and T wave. But it is usually, as I said, seen in lead, chest lead to the 5 o'clock position. P waves and QRS complex appears to be 1:1. One P wave is followed by one QRS. Because this does not happen in conduction defects. Deviation from normal sinus rhythm is called as arrhythmia, no rhythm. But remember, changes in heart rate due to phases of respiration is called as sinus arrhythmia. When you take a deep inspiration, heart rate rises or falls? Heart rate rises. When you take a deep inspiration, blood pressure rises or falls? It falls. How can you explain this? That the heart rate has risen, but the blood pressure is falling in deep inspiration.
So on inspiration, the blood flow to the right ventricle increases, so the septum will compress the left ventricle a bit. That's why the ejection fraction will decrease and it will decrease.
Put it the other way around. When you take a deep inspiration, negative intrathoracic pressure causes pooling of blood in the lungs. So the inflow to the left atrium, left ventricle is reduced. When the inflow to the left atrium, ventricle is reduced, the cardiac output will decrease. Cardiac output decrease will follow a fall in blood pressure. The fall in blood pressure causes a rise in heart rate, trying to maintain the perfusion. Okay? But how much is the fall in blood pressure? The fall in blood pressure is approximately 3 millimeters of mercury, not detectable by feeling the pulse. The three finger of the pulse is also to make sure how much is the volume. But a 3 millimeter fall is not detectable. But the rise in pulse can be detected by peripheral pulse examination. So what happens is there is an increased fall in the blood pressure, say up to 10 millimeters of mercury, then you feel the pulse is feeble. Heart rate is not felt at all. So this is called pulses paradoxes. When the ventricle, when you are in deep inspiration, you should feel a better pulse. But here you don't feel the pulse at all because of a severe drop in pressure. This is symptoms of cardiac tamponade. So the heart is not able to stretch out, heart is not able to contract that well. So the blood pressure falls significantly and the pulse is almost absent during inspiration. It is called pulses paradoxus because on palpation this was discovered, but it actually is a fall in blood pressure. Next.
With stethoscope, we'll hear the heart sound.
You'll hear the heart sound.
Feel hear anything.
I don't feel here anything. The pulse is paradoxical. Left axis deviation may indicate left ventricular hypertrophy, which means that if the left ventricle is already 3 times thicker, it will become more thicker, then more waves are going towards the left ventricle. So, axis deviation, normally the axis is around 4 o'clock, 5 o'clock. Here it becomes 1 o'clock, 3 o'clock, 2 o'clock, left axis deviation. Right axis deviation would mean right ventricular hypertrophy, left posterior vesicular block, or an old lateral semi. Now, this is a little difficult and too complex to calculate axis deviation. A simple rule is you mentally place the images of lead 1 over, mentally place it over limb lead 3, 1 and 3. If 1 shows a mostly lower down QRS complex and 3 shows a higher QRS complex, that means as if the first lead, lower QRS complex, is trying to reach for the third one, and third one shows a higher QRS complex, so it's trying to reach them. When the 2 leads reach out to each other, it is a right axis deviation. If limb lead 1 shows a taller taller R, and the lead 3 shows a deeper S, that means R is going away, and third is S is going away, and below they are trying to leave from one from the other. It means it's left axis deviation. So always just whenever you see the ECG, try to mentally place 1 over 3. When they reach out to each other, that means deeper S in 1 and taller R in 3 is right axis deviation. Other way around for left axis deviation. The PR interval is normally between 120 to 200 milliseconds. That means 3 to 5 small squares. Remember, one small square is 40 milliseconds. So anywhere where there is more than 200, it is atrioventricular block, different types, different degrees. QRS complex is 80 to 100 milliseconds. That means 2 to 2.5 small squares. So it's a very narrow QRS complex normally. That is because the Purkinje fibers causes the impulse to travel at such a rapid rate that within 100 milliseconds, the entire ventricle has reached the impulses. If the Purkinje fibers are blocked, conduction system, still the heart will contact as one unit, ventricle will contact as one unit, because muscle to muscle spread via the connection between the cardiac muscle. And that's called as, what is the communication between the intercalated disc. Muscle to muscle contraction is why intercalated disc, which shows gap junction. So if Purkinje fibers are blocked, ventricle will still contract as one unit through a gap junction from muscle to muscle. But this will take a little longer time. So the QRS complex becomes wide. Not within 2 to 3 small squares. ST segment can be depressed or elevated with myocardial infarction. We'll try to see this Y. And T wave inverted is a sign of myocardial ischemia. The normal duration is 160 milliseconds. Okay. When you're seeing the chest leads, usually in the chest leads you don't see the Q wave. You see RS pattern. And look at the chest lead 1. R is small, S is deeper. 2, 3, 4, 5, 6. R keeps on rising and the S keeps on reducing. At V4 usually it is R is equal to S. This is normal. But we find that the V4, R is equal to S occurs earlier than that. Remember, the R wave is free wall of the ventricle contraction. If the ventricle hypertrophy occurs, the R will be taller in V3, 4, 5, 6. And R equal to S may occur in V2 or V3. It means the left ventricle hypertrophy. If the transition zone occurs not at V4 instead of V5, etc., it means right ventricle hypertrophy. So right ventricle and left ventricle balance out each other, but the transition is at V4. Next. ST elevation myocardial infarction. Remember, there are 4 steps of myocardial infarction and its follow-up. Ischemia is the first thing, decrease blood flow to the heart. Then the myocardium is injured and the potassium ions will leak out of the injured segment. Third is infarction. That means that part of the heart is dying, not yet dead, but stopped functioning. Infarction. That is ST elevation. And necrosis is an old standing myocardial infarction where the tissue is dead, replaced by collagen, and no electrical activity there. And let's try to understand each one. T wave inversion. T wave is normally erect because the depolarization starts from endo to epi, and repolarization normally starts from epi to endo. Now, because of ischemia, there is decreased blood flow. The heart is also going into sluggish contraction. So, depolarization starts from endo to epi as usual, but by the time the epi has fully contracted, there is time for repolarization to start, and it will also start from endo to epi. Cardiac hypertrophy will cause such a thing to happen. Sluggish contraction will cause such a thing to happen. So, when the wave of endo to epi is slowed for whatever reason, either increase in thickness of the ventricle or because of sluggish flow of electrical, the endo is all set to restart and repolarize. So then the wave, and at that time epi is in the stage where it cannot contract because it is in the refractory period. So it starts from endo again and goes all the way to epi. So the T wave will show inversion. That's the first sign of cardiac ischemia. Decreased blood flow, decreased impulses slowing down of impulses reaching from endo to epi. Therefore, repolarization occurs from endo to epi, reversal. When there is injury, as I said, hyperkalemia, the potassium will leak out. The leaking out of potassium is seen as tall peak T wave. And then there is an infarction now. Let us understand what happens during infarction to electrical activities. The infarcted segment remains depolarized throughout. It does not undergo repolarization. That means it is an injured segment, and that injured segment will show a. Remember, normally inside the muscle is negative charge, outside is positive charge. Here, in the infarcted segment, the outside temporary negative charge remains negative charge throughout. It doesn't enter within. So now what happens is that negative charge infarcted segment will send impulses to all the other parts of the ventricle except the where the lead is. If it's an anterior wall infarct, the chest lead V3, V4 will not show any positive impulses. Impulses are going away from the anterior wall. When the impulses are going away from the anterior wall, the rest of the segments will depress. Because negative charges, that means P wave will depress, TP segment will depress, PR interval will depress, everything will depress. Because injury is going away from the infarcted segment. When the ventricle goes into contraction, QRS complex, at the end of QRS, now every part of the ventricle is depolarized, including the infarcted segment which has remained depolarized. Current of injury stops. When the current of injury stops, you get the level at which the ECG should have been. So that ST segment is called as ST junction, ST segment is called as the J point. At this moment, no current passes. So ST segment is where it is, but rest of the segments have gone down. Rest of the ECG has gone down. ST segment is where it is. Because at ST segment level, there is no current of injury flowing. Because the entire heart is deep. So we call it as ST elevation because we presume that the P wave, PQ interval, TP interval, the next contraction, they are level ground and ST is elevated from there. Actually, ST is a level ground, the rest of the things are depressed.
Depressed.
That's why you see it as a ST elevation, and this is usually transmural infarct flowing through the body wall. And later on, when the tissue is necrosed, replaced by collagen scar, no impulses are flowing through that. So, when there is a necrosis of collagen scar, no electrical activity occurs. So what you see, it is like a window, no activity. It's like a window. Through that, you can see what is happening at the other end. Right, the other end, if you are seeing through a hole to the other end, the impulses are flowing from endo to epi. The impulses are flowing from endo to epi. Now that endo to epi is flowing away from this window. So it will be seen, whatever is the R there will be the Q here. How much rise that occurs there, that much will be the depression that you can see. You are seeing from the opposite end. So that is why pathological QA. You are seeing the window of what is happening to the opposite wall. And in the opposite wall, the R wave is because of endo to epi flow. Here you are seeing impulses are going away from you. That is negative wave. Giant Q waves, as it's called. Next slide. Inverted T wave with or without ST changes. You can see this is inverted T waves with injury. The second one shows absent T waves. First one and third one shows inverted T waves. The third one also shows the SC segment is slightly depressed. The first one shows no ST depression. Okay, so these are some of the changes that occur in T wave because of myocardial ischemia. We will also understand why ST changes occur. That's also depression. Next slide. In hyperkalemia, because as I said, when the muscle is injured, potassium leaks out of the cell. So you get tall peaked T wave. When the hyperkalemia increases, the T also becomes broadened, QRS complex also broadens. And look at the PR interval. Beginning of P to beginning of R, that is normal above. And see the third one, it has widened. So, peak, this distribution is widened. QR is also broadened up, T is also broadened. And finally, P wave is missing, and you just see first one is QRS, the other one is T. P wave is missing. So this is how hyperkalemia causes sinusoidal pattern of one QRS, one T, one QRS, one T. That's all that you see.
Now this arrhythmia.
This is not arrhythmia because the arrhythmia will depend on QRS. What is the
It will become more narrow.
So the sinusoidal is
it looks like a sinus wave. That audio waves we have, those types of waves.
but the heart will be like
Heart is contracting, relaxing, but it is on the brink of infarction because the muscle has injured, potassium is leaking out. Eventually undergo infarction. Like, so the first we said injury, the first we said ischemia. That was the T wave changes. Then potassium leaking is injury. Third, next slide, is infarction. And we said it is not actually SC elevation, that is the baseline. And rest of the ECG has depressed, but we consider that as SC elevation. Look at how different varieties of SC elevation occur. There is such pattern which you see in SC elevation. So do not think of it's very geometrical SC elevation.
This one is more seen, जो हमने अब तक ज़्यादा interpret किया.
Probably the second one is the more
Yes, yes.
commonly seen. Well, that depends on what you have seen.
third वाला ज़्यादा देखा मैंने.
अब वही तो ना patient ने कैसे
So,
देखा उसको.
in the first one, you are seeing the T erect.
Yes.
In the third one, you are seeing T inverted.
Inverted.
So, all varieties occur in ST elevation. Sometimes T are altogether missing.
ये वाला भी देखा है. So this one also.
Yes. Okay, next.
Now it gets complicated. अब आएगी मजा.
See, if you notice that lead 2, which is 5 o'clock, AVF, which is 6 o'clock, and lead 3, which is 7 o'clock. 5, 6, 7 are the ones which are showing that SC elevation. 5, 6, 7 are showing SC elevation, which automatically means it is the diaphragmatic wall which is infarcted. Because diaphragm in a coronal plane is pointing downwards. So all three down segments, 2, 3 and AVF, if they are showing the changes, that means the inferior wall infarct. If chest lead V3, V4 show changes, that means it's the anterior wall infarct. If it's the free wall left wall infarct, it will be V5, V6. That's how you see it. And if the septal infarct will be seen in V1, V2. Now, if you 5, 6, 7 Now AVL is 2 o'clock, 1 is 3 o'clock, and AVR is the opposite side. Now, because there is a depression in 2, 3 and AVF, and raised SC segment, the right angle segment will show a slight SC depression, what is shown with the green arrow. But now, whether we should diagnose it as SC depression or SC elevation, because opposite diametrically right angle will show reverse changes. You have to look at which is more significant. The SC elevation is clearly more than SC depression in the two limb leads. Plus, 3 consecutive leads elevation have only 2 leads depression. That also tells you that the infarction has occurred in the 2-3 AVM inferior wall. We see why depression occurs. Acute SC elevation, example 2. The changes are a little different when it comes to a person with diabetes. Q wave starts appearing quite early. Maybe it is already there. Some arteritis of the diabetic vasculature, etc. will show. But Q waves usually are pronounced only after the episode of infarction is over. Next slide. This is what will be seen in an echocardiogram. So we will not show here. Next. The coronary angiography. So what you are seeing in the left figure, left hand side, black vessel running downwards, that is the left anterior descending. This one, left anterior descending. And the other one is left circumflex.
This one.
Left circumflex. On the right hand side, you are seeing the right coronary artery. And what you are seeing, the terminal part of right coronary artery is what is forming the interventricular septum on the diaphragmatic surface. So, right coronary artery terminating in the posterior interventricular artery. Yeah. So, depending on posterior interventricular artery, you decide cardiac dominance. If the posterior interventricular artery is from the right coronary, you call it as right cardiac dominant. If it is from the left coronary artery, it is left cardiac dominant. If it is both coronary arteries, it is co-dominant. But point to be remembered, whatever be the dominance, more musculature is supplied by left coronary. Because only 1/3 of the septum, if it supplies posterior interventricular artery, that's not a very great deal of blood supply. The main artery is the anterior interventricular, which supplies 2/3 of the interventricular septum. And most of the, the bundle branches are also lying in the septum. In fact, anterior interventricular is also the most frequently blocked, and it causes a massive anterior wall infarct. That's why the anterior interventricular, which is clinically called as LAD, left anterior descending, is called as the widowmaker artery. Males are the ones who die because of coronary, the woman becomes a widow. The anterior interventricular or LAD.
बाइपोस को इतना टेंशन देती है कि वो बेचारा अटैक से मर गया. That's how widowmaker. So there is a gun which is also called as a widowmaker.
Why do you have a gun, sir?
Yeah. पर्टिकुलरली वो स्नाइपर या जो भी फ्रंट पे आर्मी के काम करते थे, तो वो बंदूक की वजह से दे स्टार्टेड गेटिंग मोर टारगेट्स. विडोमेकर नाम का एक कोई गन भी है.
Anyway, the stress causing cardiac arrest, which means students have no stress at all.
No,
Okay? And person who is in war, because the adrenaline rush, usually doesn't die there.
Yes.
Then when he is retired from life, he is doing gardening,
Yes.
little jogging here and there, suddenly goes into cardiac arrest.
Getting scored.
Where is the stress there? So it is all coronary blockade,
Yes.
which keeps on progressing. If you see the left hand side, a complete block by the atherosclerosis with a thrombus. A spherical structure above is the thrombus, atherosclerotic, which is sharp peak, which blocks the thrombus. So this causes a transmural ischemia. So you see classical ECG SC elevation, it is called as SC elevation acute coronary syndrome, or STEMI, SC elevation myocardial infarction. If there is a reduction in blood flow, it is called as, it will produce a subendocardial ischemia, it will produce SC depression, and it's called as non-SC elevation myocardial infarction or unstable angina. Let's try to understand this. When the entire wall has not been affected, that means a part is injured, let's say the anti-wall is injured, only endocardial part. It means that injured part will give current of injury, and the current of injury will go through the normal wall anteriorly and come to the chest lead
V1, V2.
V3, V4. V1, V2 is septum.
Septum, yes.
V3, V4 the anterior wall. So the current constantly flows towards V3, V4. That means the whole ECG has risen up. Because constant current of injury towards V3, V4. Because the endocardial portion is affected, which is injured.
everything comes up.
Everything comes up.
Brings down.
When J point occurs, the entire heart is gone into depolarization. Current of injury stops. The SC segment goes down. SC segment tells you what is the baseline of the. So SC segment going down is actually rest of the part going up. So in the subendocardial infarct, you will get SC depression. Now we also said that when there is SC elevation, diametrically opposite segment will show depression. But here, SC depression is not very pronounced. That the diametrically opposite segment should do a raised ST. So when you get SC elevation and diametrically opposite segment showing a slight depression, means it is transmural infarct, STEMI. If you get ST depression with insignificant ST elevation at the diametrically opposite segment, it means it is non-STEMI. Let's look at the next slide. Notice the coronary artery. It is supplying the epicardium, it is supplying the myocardium, then it stops there. It does not supply endocardium, it does not supply Purkinje fibers, it does not supply subendocardium. Then who supplies it? The blood in the lumen. The blood in the lumen supplies it. So blood in the lumen will freely supply endocardium. There's no problem at all. Blood in the endocardium will also supply Purkinje fibers.
Diffuse.
Little lesser. And blood will supply even lesser subendocardium. The subendocardium is the area which is called watershed. Coronary artery thinks lumen will supply. Lumen thinks coronary artery will supply. In the end, nothing supplies. So then you get a subendocardial infarct. And with the subendocardial infarct, you can now understand where that is. That is slightly in this figure to the right of that yellow Purkinje fibers. If that part is injured, impulses will flow to the rest of the myocardium in entire cardiac cycle except during depolarization of the whole ventricle. The current of injury flows throughout the ECG complex except ST segment. Because at that time, during the ST segment, everything has been depolarized. No current of injury flows at that point. Next slide. Progression of acute coronary syndrome. Risk factors, inflammation of coronary artery, that is arteritis, atherosclerosis of coronary arteries, that means lipid plaques. The plaque rupture, erosion, that means the plaque has become pointed, which is the site where thrombosis will get blocked, atherothrombosis. M is missing, the thrombosis of coronary arteries, which will result in acute coronary syndrome. This is how the disease progresses. Next. This is what same thing explaining that it's a transmural infarct, the ST gets elevated, and next, when it is a subendocardial infarct, ST gets elevated. Notice the earlier figure where there was a prominent ST elevation. In contrast, there is a little less ST depression. You don't see it as classical. Next. So how do you manage MI? The pain is treated with nitroglycerin. Nitroglycerin is a coronary vasodilator. But after the segment is infarcted, then nitroglycerin is of no use. But at least when an area is infarcted, the adjacent areas are ischemic. The center of the infarction is dead, but the peripheral areas are still alive, but they are having decreased blood flow. So nitroglycerin does help to some extent. But the pain can only be cured by morphine. The continuous 30 minutes already suffering. You don't want it to suffer even further. Anticoagulant is required because the clot is the one which causes. Aspirin, low doses, is a blood thinner. That is usually useful in long-term therapy. Immediately, if you want to prevent further coagulation of the clot, heparin. Nowadays, what they do is low molecular weight heparin, which is having less side effect, and the classical heparin.
Clopidogrel also there. Clopidogrel.
But they give a combination of rosuvastatin.
Percutaneous coronary intervention is a term that is used, which can be, you have just gone into coronary artery. Now you are thinking what to do. Whether you should do angiogram, after doing angiogram, whether you want to do angioplasty, or whether you would offer the patient coronary artery bypass. So percutaneous coronary intervention within 90 to 120 minutes. You can't be more than that. But should you give fibrinolytic agents? If it is useful, usually within 30 minutes. That's why it's can arrival to hospital to prick should be within 30 minutes. You have taken 60 minutes to reach the hospital, but after it reaches the hospital, within 30 minutes you have to decide fibrinolytic agent is required to be given. Oxygen when PO2 is lesser than 90%. Percutaneous coronary intervention with angioplasty or CVG. These are the lines of treatment. Rehabilitation and prevention. Lifestyle changes, exercise, diet, good smoking, keep a healthy weight. Aspirin, blood thinner, beta blocker, beta blocker, because beta
B उड़ गया
beta blocker is the one which causes the heart to go into slower contraction. ACE inhibitor reducing hypertension. Statin reducing lipids. Aldosterone antagonist is the left ventricular dysfunction because pulmonary edema is the thing which happens in left ventricular dysfunction. You may think it is acute coronary syndrome. You may think it is STEMI, etc. Gastroesophageal reflux disease can cause the heartburns, chest pain, pulmonary embolism, tumors of lungs, pneumonia, rib fracture, costochondritis can cause continuous pain beyond 20 minutes. Aortic dissection is the aneurysm which is now ruptured. Esophageal rupture, tension pneumothorax, pericardial effusion are some of the differential diagnoses. Now look at this case. A 54-year-old woman complained of sudden excruciating knife-like pain in front of the chest. Looks like coronary because beyond menopause, women and men are equally at risk to coronary artery disease. And also in her back between the shoulder blades. Now women do have some strange pains in the back, even cardiac origin. On close questioning, she said she felt no pain down the arms or in the neck. Usually coronary disease causes pain along the inner side of the arm or the neck. Neck is because the flow of blood is towards the neck, so the pain is carried towards the carotids. But here is a classical thing. Her blood pressure was 200 by 110 millimeters in the right arm, but 120/80 in the left arm. That means there is some difference in the right subclavian and some difference in the left subclavian.
This mostly happens with Takayasu patients.
Huh?
Patients with Takayasu disorder.
The severe nature of the pain and the radiation to the back made a preliminary diagnosis of aortic dissection. Myocardial infarction commonly results in referred pain inner side of arm or up to the neck. Pain impulses originating from a disease descending thoracic aorta passes through the sympathetic nervous system along sympathetic nerves that are referred along the same spinal nerves, T1 to L2. So that's why the pain is radiating in the back. In this patient, aortic dissection had partly blocked the origin of left subclavian. Remember, right subclavian is the beginning of arch of aorta. Left subclavian is near the end of arch of aorta. So descending thoracic aorta, when it is affected, it could affect left subclavian as well, which is why the lower blood pressure in left arm. How else can myocardial infarct present? The classical presentation of chest pain occurs in about 50% of the women. Look at the other way around. In 50% of the women, there will be no chest pain, yet it could be MI. Women also commonly experience back pain, neck pain, indigestion, heartburn, lightheadedness, shortness of breath, fatigue, nausea, pain in the back of the jaw. Such things are what is seen. All such things in postmenopausal women, one must think of MI. Sweating, nausea, vomiting and fainting with or without chest pain. And in diabetics, because of neuropathy, pain is not felt. The nerves are dead, so you get silent myocardial infarction. Painless chest pain. Painless MI. Next. This is a suspecting myocardial infarction. Chest pain greater than 20 minutes, not relieved by rest or nitroglycerin. Smoking is one of the chances that myocardial infarction could be there, and it would be a variant presentation in smoking myocardial infarction. Hypertension is the cause. As I said, hyperlipidemia, diabetic, sedentary lifestyle, reduced intake of proteins, these are the avoidable causes. Male, gender, family history, unavoidable causes. Now we'll have some MCQs to test how much have you understood. You initially suspect this patient is having acute coronary syndrome. which of the following symptoms would not typically be consistent with the diagnosis? We said that nausea, vomiting does happen with myocardial infarction. Relaxation is classical. Palpitation is there. Shortness of breath does occur, that's why we said oxygen therapy. Palpitations is increased heart rate which you feel. That is not necessarily myocardial infarction. So classical symptoms associated with acute chest pain relating to pain, jaw, back, dyspnea, nausea, vomiting, epigastric nephros, diaphoresis, there is excessive sweating, syncope or near syncope, fainting. Palpitation is not typical of ACS. Diabetic patient may not manifest with any of these typical signs and symptoms. Also, smokers. Next. All of the following are primary risk factors for development of coronary artery disease except tobacco use is the greatest risk of coronary artery disease. Hyperlipidemia, we know it is. Hypertension also we know it is. Male and age, both are there. But male is more likely to be having myocardial infarction rather than age. Age is just a number.
Now we can say.
There are people, yes, we do see more myocardial infarction as the age advances, but not the age which is causing the myocardial infarction. Because now we see MI in younger patients, and there are some champion livers who don't die of MI. It's all lifestyle changes. Age is not thought of as a primary risk factor, whereas MI does increase with age. The other factors, diabetes, family history, premature coronary artery disease, are the primary risk factors. Family history. Next. You see the ECG. Where do you see some typical changes?
V2,
V1, V2, V3. And to some extent V4. So this is V1, 2, 3, 4. That means it is septum and anterior wall. Now, what is the septum supplied by?
V1,
Left anterior descending. What is the anterior wall supplied by? Anterior wall left ventricle is supplied by and left anterior descending as well as circumflex. So because circumflex is supplying some part of the anterior wall, the V3, V4 are showing less changes as compared to V1, V2. They typically affected the interventricular septum by the widowmaker artery. Your patient's initial ECG is shown in the figure above which you saw. The most likely diagnosis is SC elevation MI. SC elevation MI. The ECG tracing demonstrates SC elevation in 2 or more contiguous leads. That is very important, 2 or more contiguous leads, because if you see it in one lead and you don't see the adjacent lead, something can be wrong with that tracer at that point. The patient is normal sinus rhythm, atrial fibrillation is ruled out. STEMI often has little or no specific ST TUV changes. If at all, it shows slight ST depression, non-STEMI. Pericarditis is diagnosed in a setting of chest pain with diffuse ST segment elevation. Here it was very clear and prominent. And sometimes VR segment depression as well. These changes are not seen in this case. Next. The same one, just to repeat, that if you look at the lead 1, 2, not 2, 1, 3, place 1 over 3.
Oh, exactly.
so going towards.
What is going toward?
Leaving.
The R wave is prominent in 1, S wave is prominent in 3. the peaks are moving away from each other,
Yes.
leaving left axis deviation.
Left axis.
Is it clear? You go back. You place the 1 mentally over 3, and then you see that the peaks are moving
Yes.
away from each other.
Yes.
Left we leave, right we reach. And you can see V1, V2, V3 contiguous segments. You have correctly diagnosed SEMA in your patient and decide to pursue reperfusion therapy. The closest hospital with a cath lab, which will do that percutaneous CI intervention. Transfer the patient to the cath lab 2 hours away. Forget reperfusion therapy as its has been become so long back. Or begin administering a fibrinolytic agent. Remember, the pain started 6 hours back.
Yeah, there is no use of phenomenon.
You have to try to do a reperfusion therapy as well as use fibrinolytic. Needle, door to needle, 30 minutes. Next slide. The patient should be given a lytic agent if he has no absolute contraindication. That means he has no other bleeding disorder, etc. Lytic agent should be started within 30 minutes or door to needle time. Cath lab was available within door to balloon time. If it is less than 1 to 1.5 hours, then you would think of transfer. 2 hours is too long a time. You have to treat in that golden hour. Withholding reperfusion due to symptoms within 6 hours is incorrect. Reperfusion should be started within first 12 hours and even up to 24 hours. What do you do here? Next. This is what Americans recommend. Reperfusion therapy is indicated in all patients with symptoms of less than 12 hour duration with persistent ST elevation. And then if it is an anterior chest wall, left bundle branch block will occur. Reperfusion therapy, preferably primary percutaneous intervention, is indicated if there is evidence of ongoing ischemia, even if the symptoms have started more than 12 hours. That means that ischemia, T-wave inversion, the hyperkalemia, if it is seen to be progressing in the other leads also, you go for reperfusion therapy. It's also, if it's more 12 to 24 hours of duration, but usually more than 24 hours without any signs of ischemia, it is not recommended. That's what they talk about reperfusion. Next. Your initial lab test, when your patient comes to you, take the blood, show cardiac biomarkers such as creatine phosphokinase, creatine kinase, myocardial band, troponin T. Which of the following will correlate with the amount of myocardial infarction? Initial concentration or change in concentration, or both A and B, or neither A nor B? Both. Initial concentration and a rise is classical. So, both initial concentration and change in the curve over time have mammography should do correlate with the amount of infarcted myocardium. Next, which of the following therapies is not indicated for a patient with SEMI upon arrival? Should we start administering aspirin, beta blockers, nitrates, lipid lowering agent, oxygen?
Beta blockers.
Lipid lowering agent.
Lipid lowering agents. Lipid lowering agents take a long time for the lipid to lower. That's what I think to be done. Beta blocker might be required. You might save the patient. Next slide. Lipid lowering agent. While other therapies are indicated in nearly all patients, starting a lipid lowering agent upon arrival has not been shown to be beneficial. But if the patient was already on lipid lowering agent prior to arrival, it should be continued. So no new therapy of lipid lowering agent to be started. But you have to start it before you discharge him, because eventually he'll have high lipid level. In a hospital, day 3, you are preparing to discharge a patient to home. He has done well after the lighting therapy with rapid resolution of SC segment, no further symptoms. You set up cardiac rehabilitation program for a patient to follow up after discharge. He questions the utility of such a program. He has to come from such a large distance. Is it really helpful? He asks you. You tell him cardiac rehab has been shown to decrease further cardiac morbidity and mortality, or early cardiac rehab has been linked to increased admission for chest pain so that you can quickly be, what do you say, taken in again, or patient who attend cardiac rehab are unlikely to require long-term medication. So if you come for rehab, you don't have to take long-term medication. Next slide. Cardiac rehab has shown to improve quality. Unfortunately, people don't understand this. That's why only a minority of such patients participate in such programs due to non-compliance, financial concerns, and lack of reference. At discharge of patient's medication include aspirin, beta blocker, statin, ACE inhibitor, and nitrate. Which of these should not be prescribed for long-term therapy in this patient?
Nitrate.
Nitrate is used only for the acute phase when he is having chest pain. Nitrate has not been found substantial benefit for long-term post-MI therapy. Unless there is some residual ischemia. The remainder of the medications are appropriate for this patient and should be continued indefinitely if tolerated. If patient reuses discharge medication, let's then pose the question. He understands the benefits of most medications. However, he wants to know why should he take an ACE inhibitor indefinitely? Which of the following is not an indication of lifelong ACE inhibitor? Is hypertension useful in ACE inhibitor? Congestive cardiac failure, left ventricular systolic dysfunction, tobacco use,
Tobacco use will cause increased blood pressure, no sir?
but tobacco use is not the cause for ACE inhibitor. Diabetes, you have to take ACE inhibitor. So, the indication of using ACE is lifelong because of the other factor. Tobacco is maybe an associated factor. The person may be not on tobacco also. Even then you have to continue the ACE inhibitor immediately. Next slide. Right? That's what I mentioned. Last slide. The patient returns after 2 weeks for a symptom remitted treadmill stress test. Stress test post-MI provides which of the following benefits? Acts as a guide for exercise prescription. Aids in identifying residual ischemia. Provides prognostic information. All of the above. All of the above. Next slide. Post-MI stress testing, an established value of risk determination and assessment of functional capacity. All of the answers identify other potential benefits of post-MI stress testing. Of note, stress testing should not be performed for the first few days post-MI. That means first 2 to 3 days we do. From day 4 to day 7, a sub-maximal stress test can be done. Only after 2 weeks should the symptom-limited stress testing is recommended. Should we stop here?